Okay, so as Vivek very correctly said, that Lamar is a fashion. And you see all these younger colleagues of mine in my team, they are running after the Lamar. And the Vivek is in forefront, like he presented very recently. He very nicely showed that there is a difference between Lamar and Ellison. And if you see Lamar, it creates an extra attachment in the femur. If you remember all those ALL anatomy, there is no extra attachment in the femur. Rather, ALL is extension of the LET. And then, the IT band. And if you see Ellison, it is exactly the what? This is extension of an IT band on its lateral side. Probably that is why it is a very much, anatomic. That is the reason why, in between 2019, when I taught Vivek first time this, Lamar technique in 2023, we all used to do Ellison. We had 61 cases. But later I switched to Ellison, but Vivek is still running after the, Lamar technique. Why I switched from Lamar to Ellison? The first is the ease of performance. If you see that, it's very simple. I demonstrated yesterday also. Detach from the Gerdy's tubercle, pass it under the LCL, and get it attached to the same position. If the patient is ligamentously laxed, you can still, do more anteriorization. But you see, Vivek also showed where to fix in the femur for Ellison. Still confusing. Some people fix in the modified Lamar's position, original Lamar position, then Krakow position, McIntosh position. There are 7 different positions in literature described where you can fix into the femur side. It's all confusing, Don't follow this. Graft position, Vivek didn't talk about this. When to fix and at what position you have to fix the modified Lamar is very much. You see that? Hold the graft taut, but not over tension. Less than 20 Newton. God knows how when you are pulling it, it's giving 20 Newton or 200 Newton. Nobody knows, because this is completely different. With the knee at 60 degree of flexion and the foot in neutral rotation to avoid lateral compartment over constraint. Also don't say that, don't put in varus, put in valgus, all those. Ellison, put it back in any position of the knee, in any position of the foot. It's very simple to do it. Third reason, Lamar over constraint the knee, there is no doubt. Read in between line, 10 lines in between, but what you know is that this paper says that superficial Lamar, deep Lamar, both of these, they over constrain the knee. Deep Lamar more over constrain the knee. That's why even this biomechanical study suggests that forget about who did it, Brian David did it, or who did it. Don't forget there is not only one name. There are other people also, But this is over-constraining, there is no doubt on it. High risk of tunnel convergence. We all know that up to 70% there is a chance of having a tunnel convergence. That is why even Gategood, who popularized this Lamar technique, has shifted from making a tunnel to putting a staple. Now people use anchor. Even Vivek moved out of making a tunnel from putting an anchor now. Some people put a screw, Some people, this is, even still go with the tunnel. So much of confusion, because there is high chance of tunnel convergence. Ellison is more biomechanical. Don't forget, why to over-constrain? Do an arthrodesis. Patient doesn't require even, knee ligament reconstruction. So why to over-constrain the knee? Wait for another 5 years. You'll have lots of lateral compartment osteoarthritis after this Lamar procedure. And this has been mentioned that there is a possibility of lateral compartment, osteoarthritis in the stability 1 if it is done very tight. So this is the biomechanical study again. So Ellison is anatomical because this is extension of the IT band into the tibia. This is anatomical. This is just being passed underneath. And how it acts? It acts as a pulley. Both Lamar and the Ellison, it is not where it is attached acts. When imagine this knee is extended now, then the curvature of your, IT band will create, prevention of internal rotation. It is not the attachment of the femoral side or attachment of the tibial side. So probably we need to understand what is the mechanism of injury of lateral extraarticular tenodesis. Then only you will be able to say that which is going to work. It is not above the LCL. Everything which is below the LCL, that is going to work. It's not Lamar or Ellison. So, ladies and gentlemen, there are lots of issues with the Lamar. Tunnel convergence, over-constraining of the knee, fixation point of the femur, fixation method in the femur. We still don't know what to, what to use to fix in the femur. Knee kinematics, position of the knee and foot, and so forth. These all are neutralized in Ellison, but the mechanism of action, if you understand how it works, are the same. So it will not be inferior one. However, I absolutely agree that there are lots of paper on Lemire compared to the Ellison, because not many people are doing this. But remember, ladies and gentlemen, we have moved from non-anatomic to anatomic. This is the ACL evolution, how we moved from non-anatomic to anatomic. The whole world is moving from non-anatomic to anatomic, okay? So the final few slides, rule number 1, as Vivek said, boss is always right. And the rule number 2 is, even if he's not right, remember rule number 1. So this correct remains true here as well. And just predict after 5 years, these people who were running after Lemire, they will still be running, and the Lemire will get married to Ellison, and she will become Mrs. Ellison. Thank you very much. I'll rest my case.
Thank you, Amit. Now, Vivek, do you have any rebuttal points?
From there only.
Take this mic.
I absolutely agree in most of the logics, most of the points which Sir has mentioned, but few things. I don't think ALL as a structure, Stephen Claes did not describe ALL as non-ligament thing. He described it as the pure ligament. He dissected the knee, and in all his dissection, he got some ligamentous structure which has definite structure attachment at the femur and tibia. So we have to reconstruct, I think, the ligament, not the tendon. Second, fixation in tibia, even Ellison is not there. Some fixes was fixed with sliver of bone, fix it anterior to girdis to its attachment. Some fixes at the same point, some fix with staple, some fix with anchor, and some attach it with some fibers of FCL. So Ellison is also not 100%. The technique is also not 100%. And regarding position, the femoral attachment position, I think after the stability 1 and 2, it almost confirmed that you have to put the femoral attachment right at the point where ALL is attached. So that is also done. Fixation of implants, so people are getting away from interference screw fixation, because interference screw fixation, you have to pull it tight, and while doing so, over constraint occurs. So they are going more of the surface fixation, like it's not about only tonal conversion. It's about when you pull it, it's more over constraint. That's why they are going away from interference screw to surface fixation, like staples and anchor. I think that's it.
Thank you very much. We have done 72 cases as well, of Lemire itself in last 1.5 years. And there are, I know I'm in touch with some of the other, except David, who is doing Lemire procedure. And then, Ellison is way to go, because this is more simple. It's more anatomical compared to that. And then you see ACL reconstruction is not anatomical. This is near anatomical. So this is, you go near anatomical, and it's not complicated. You haven't done Ellison. I have shown you once. If you do Ellison, Lemire is 20 times difficult. For the starter, if it is indicated, do Ellison. Yes, there is still role of Lemire in certain cases, in very high demand patients, 2 failures. In that case, still there is a role of Lemire, but for the starters, I think Ellison is the way to go. And next 5 years' time, you'll get some more publication which will be comparable with the Lemire technique. Thank you very much.